Hello everyone, today we are discussing a respiratory emergency which is called as acute respiratory distress syndrome. In this we must know what is cardiogenic and what is non-cardiogenic pulmonary edema. In cardiogenic pulmonary edema there is increase in the left atrial pressure secondary to left ventricular failure. Due to rise in left atrial pressure, there is congestion in the pulmonary circuit which leads to pulmonary edema. So the fluid is transudate due to increase in pressure. Okay, in non-cardiogenic pulmonary edema, which is also called ARDS, the ARDS occurs secondary to swine flu or bird flu, because swine flu, bird flu virus ultimately damage the pneumocytes, which leads to decrease in surface area, and damage to pneumocyte means alveoli will collapse and there will be hypoxia. Hypoxia will damage the endothelium which forms the gap junction. So gap junction is damaged, alveoli is damaged, alveoli is collapsed. So there will be leakage of fluid from pulmonary capillary into the alveoli. There is no damage to the blood vessel. Due to damage of gap junction, there is leakage of fluid. So it is not transudate. Okay, it is exudate.
Amazing!
So injury to type 1 pneumocytes will lead to exudative edema, which has high protein content, and injury will lead to increased in inflammatory cytokines like IL-1, 6, TNF alpha, which will lead to recruitment of neutrophils. This edema, this protein, high protein and neutrophil will form a hyaline membrane. It is why the ARDS is also called as hyaline membrane disease. Hyaline membrane will decrease the transport of oxygen. That is why DLCO will decrease. And type 2 pneumocyte injury will lead to decrease in surface tension because of decrease in surfactant production, and it will lead to alveolar collapse. Alveolar collapse due to type 2 pneumocyte injury and hyaline membrane formation due to type 1 pneumocyte injury combinedly will lead to acute respiratory distress syndrome. So this was the pathophysiology. We will now see what are the triggers of ARDS. So there are direct causes and there are indirect causes. Direct are pneumonia, aspiration of gastric contents, pulmonary contusion, near drowning state, toxic inhalational injury. Indirect में first is sepsis, second is severe trauma, multiple bone fracture, flail chest, head trauma, burns, multiple transfusions, drug overdose and pancreatitis. Coming to the clinical features, there will be sudden onset respiratory distress with bilateral infiltrates. Okay, in chest x-ray we can see that. There will be normal left atrial pressure because we saw left atrial pressure increases due to left ventricular failure when there is cardiogenic cause. So ARDS occur due to non-cardiogenic cause. So there will be normal left atrial pressure, and we see decreased PO2 due to hypoxia. So in ARDS, damage is directly in the lung. That is why it is called as non-cardiogenic pulmonary edema. Now we will study the timeline, that how acute respiratory distress syndrome progresses. First is exudative phase. In first 7 days, the pathophysiological changes occurs like intrapulmonary shunting हो गया, increase in work of breathing, decrease in PO2 and increase in PCO2. So this is type 2 respiratory failure. So increase in dead space. So these are pathophysiological changes. After 7 days, there is proliferative phase in which body tries to repair. So lymphocytes take over the neutrophils. So there will be proliferation of type 1 and type 2 pneumocytes. After 21 days, there will be fibrotic phase of the lung, which will require the supplemental oxygen for rest of their life, and it result in pulmonary artery hypertension as well. So coming to diagnosis, we use Berlin criteria. It is used to diagnose ARDS. Firstly is the timing. Within 7 days from inciting event to development of respiratory symptom. So timing is important, like if sepsis occurs, RT occurs, so within 7 days it should develop, that then it will be called as ARDS only. Second is the chest imaging. Bilateral infiltrates are seen, okay, like consolidation, etc. Third is the 2D echo, which will be normal because it is not cardiogenic. Then fourth will be hypoxia, which is significant. PaO2 to FiO2 will be less than 300. When it is less than 300, we call it as mild. Less than 200 is moderate, and less than 100 will be severe. Then what are the synonyms of ARDS? It is also called as blast lung, shock lung, Dahneng lung, diffuse alveolar damage, traumatic wet lung, non-cardiogenic pulmonary edema, या stiff lung syndrome. So the keywords to diagnose ARDS are sudden onset respiratory distress, chest X-ray with bilateral pulmonary infiltrate, PaO2 to FiO2 less than 300, which is most important diagnostic criteria, and absence of left atrial hypertension. Coming to the treatment aspect of volume trauma, so we use low volume ventilation in these patients, 6 milliliter per kg, to minimize barotrauma to the chest. Normal tidal volume is 12 milliliter per kg, but in these patients we use 6 milliliter per kg. Plateau pressure of ventilator should be less than 30 centimeter water, and respiratory rate of ventilator less than 35. Prone position ventilation can be done, but there will be risk of extubation or CVP line can be lost. Third is extracorporeal membrane oxygenation when heart and lung are too weak for ventilation. Fourth is limited fluid and diuretics to maintain left atrial pressure. Fifth is ensured neuromuscular paralysis agar hai, then we can give cisatracurium for effective ventilation. And please remember, there is no role of steroids or surfactant therapy or any high frequency jet ventilation. So that is it for today, and hope you like the video. If you like the video, then subscribe to my channel.